Could you describe the difference between ADH, ALH, and LCIS?
So there are three breast lesions that are considered high risk. And the first one is atypical ductal hyperplasia, or ADH. The second one is atypical lobular hyperplasia, which is ALH. And the last one is lobular carcinoma in situ, which is LCIS. That LCIS is a misnomer because it's not a carcinoma in situ, so it is a benign lesion, but it's a high-risk lesion. So atypical ductal hyperplasia and atypical lobular hyperplasia are considered high-risk markers. So patients who have that lesion are considered at higher risk of breast cancer in up to 30 to 40% increase lifetime risk of having breast cancer. Usually, we operate on patients who have atypical cells to rule out cancer. The patients who have atypical ductal hyperplasia have a higher risk of upgrade, meaning when we operate on them, finding cancer. Now, the range of that upgrade is pretty broad. I would say it's anywhere between 5 and 30%. The patients who have atypical lobular hyperplasia, in some cases can be monitored, and in some cases need surgical excision. And that is something that you should discuss with your surgeon or breast specialist to see who qualifies for an excision of those lesions. Now, LCIS is a lobular carcinoma in situ, and as I mentioned to you, it's a misnomer. It's also known as lobular neoplasia in situ. And patients who have LCIS are usually patients who are increased lifetime risk of up to 20% of having breast cancer. And it is considered a marker for patients. So a patient who has these three lesions, we want to have them be seen in a breast specialist, want to be followed with routine screening mammography starting at 40 every year, not to be skipped, as well as potentially adding an MRI every year and a clinical breast exam by a breast specialist. In some cases, we send those patients as well to medical oncology for chemoprevention. So chemoprevention is taking an estrogen blocker to decrease their lifetime risk of having breast cancer. Again, everybody should be treated based by case, and it's one of those things that if you have that on your biopsy, you should seek consultation with a breast specialist.